So a very good evening to one and all who's joined us from the community, and it's indeed a great pleasure to connect with the rest of you watching this episode. And this is a very, very special episode by a very, very special doctor. Before we get a sneak peek into what we're going to be discussing about, it's a pleasure to introduce Dr. Rammohan Bhat, the consultant nephrologist of Narayan Healthcare from the city of Bangalore. Well, that's not all. It's also my privilege to say that Dr. Ram Mohan is the president of the Ramakrishna Charitable Trust, which was formed in January 2020. This trust is to help the needy kidney patients who need support. And on behalf of the community, I would like to say thank you, Doc, for everything that you've been doing behind the scenes. And today we're going to be discussing a very, very important topic, a topic that is already been discussed within the community and has definitely caught a number of people's attention. Definitely a topic close to my heart, understanding the peritoneal dialysis and the hemodialysis. And who could be the better person than Dr. Ram Mohan himself? And may I request Dr. Ram Mohan to kindly take over.
Thank you so much, Marian. At the outset, I would like to thank Mrs. Vasundhara and Sandhya, who were kind enough to invite me to give this lecture to all the patients in your group, the Kidney Warriors. I've heard great things about all of you. You're doing a yeoman service, trying to support people who are going through a very tough phase in their life and filling them with a lot of hope that things will and definitely will turn around with time and everything will pass. With that, I would straight away go to what I have been asked to talk. So if we can get the slides on the screen, please. There we go. Yeah. So I've been asked to talk about the comparison between the two modalities of renal replacement therapy that is available to us, that is hemodialysis and peritoneal dialysis. What I'm going to touch upon, if we can go to the next slide, is I'm going to very briefly set the scenario by telling just a couple of things about acute kidney injury versus chronic kidney injury, and when does someone require dialysis, a bit about hemodialysis. I think everybody knows about hemodialysis, a bit more about peritoneal dialysis, and then let's compare about the advantages and disadvantages of the two of them. So acute kidney injury, the next slide, please. Acute kidney injury involves development of dysfunction of the kidney over few hours to days. When I say dysfunction of kidney, as you all know, normal creatinine would be somewhere around 1 to 1.3, depending on various labs that report these values. So even if creatinine goes from 1.0 to 1.5, we would call it as acute kidney injury. I wouldn't like to call it as failure because the kidney hasn't failed. It is not shut down completely, but there is an injury to the kidney. So we have kind of shied away from calling it as failure. Even the chronic kidney disease, we don't call it as chronic renal failure anymore and call it as disease intentionally because we don't want to scare people. Even when creatinine has been 2 for few years, previously we would call it as moderate renal failure. We don't like to call that as failure anymore. So kidney dysfunction, which evolves over a very short period of time, just a matter of few hours or days, we would call it as acute kidney injury. Most of these people are already in hospital or would end up requiring hospital. Very few, might manage without getting into hospital. And most often than not, it is part of multiple organ dysfunction, which is happening in the person. And there are 3 stages to it: stage 1, 2, and 3. And stage 3 is the worst. And most people with stage 3 would end up requiring dialysis. Not all of them, but most of them would end up requiring dialysis. And this dialysis usually is temporary. On the other hand, chronic kidney disease, it evolves very, very slowly over many, many months or years. By definition, minimum 3 months. It's usually over many, many years and slowly progressing. Most of the times people are well. So that is why we see more than 50% of our patients, they are diagnosed with quite advanced CKD by the time they present to us with any tiny weeny symptoms. So it goes on very silently inside and is undetected unless that person gets regular health checkups, especially the ones who are at higher risk, like hypertensives, diabetics, people with heart issues, etc. And it might be limited to kidney alone. It might not be part of multiple organ dysfunction, and it could be part of multiple organ dysfunction as well in somebody who's got diabetes, because diabetes, uncontrolled diabetes, affects multiple organs, including the eyes, the nerves, the heart, etc. It could be involving multiple organs, but usually, it is limited to the kidney. And there are 5 stages to it, as most of you will know. And stage 5 is when the kidney function, both the kidneys put together, is less than 15%. However, dialysis will be required usually when kidney function is less than 10%. I'll come to that later. And once we start dialysis, usually it is permanent, or until the person ends up having a kidney transplant. When does somebody require dialysis? And here I'm going to limit myself to CKD, because acute kidney injury, there are multiple things, and these are best left to the doctor treating the patient, the nephrologist treating the patient. Even a nephrologist sitting far away without having seen the patient will not be in a position to decide, leave alone a common man. So I will limit myself to CKD. So in CKD, the most important thing is the person, the patient. So I would shy away from talking about creatinine initially, because it is what is happening with the person which is more important than the blood reports. That's why I put the symptoms first. Very vague symptoms that we see: nausea, loss of appetite, weakness, tiredness, breathlessness, confusion, severe itching, weight loss. So everything might be okay. Even the creatinine might be fine. I just saw a lady yesterday whom we initiated on dialysis. She has lost 20 kilograms in 1.5 years. So she's gone on very strict diet. Her creatinine has remained stable at 6, but from a weight of 73, she's gone down to 53 in a matter of 18 months. She still doesn't have most of the other things that I tell you, except for intense tiredness. All that she does is sleep all through the day. And she's not eating much. Whatever she's eating, she's not digesting it properly or assimilating it. So she's just losing weight and wasting away. That is also an indication to start somebody on dialysis without waiting for the potassium to go up or fluid to build up. Plus, usually when the kidney function goes down to less than 10%, that is the GFR. So based on the creatinine, the sex of the person, the age of the person, and the race of the person, we come up with something called as the estimated GFR. Usually when it is less than 10, in single digits, 9 or below, that is when people end up requiring dialysis. Very rarely, people, even when GFR is more than 10, their potassium might be very high, their fluid buildup in the body might be so bad that we cannot manage it with fluid, as I put it in the third bullet point there. Fluid overload or high potassium, which does not respond to diet and medicines alone, might require dialysis even when GFR is more than 10. And we should always prepare in advance. As kidney function drops below 20%, we should start having the discussion about what modality of dialysis, and plan for it. By the time GFR hits 15 or just under that, we should plan a fistula at least 3 to 6 months in advance. It is very difficult to predict how quickly the GFR will drop in somebody whom I have seen new. But if I've known a person for last 5 years or few years, at least a couple of years, and we have seen the trend of creatinine, we can predict the trend, because it will remain the same unless there is some acute problem like an infection or something like that, which can suddenly drop the kidney function. Next slide, please. That will bring us nicely to the various the 2 options of dialysis available. So the options available for somebody who reaches CKD stage 5 is either a preemptive transplant, which is the best one for anybody who can who is eligible for it. Maybe a very small proportion, 0.1% of people might not be eligible for it because a condition that they have got which has caused kidney failure, which can recur back in the kidney. And then there is a small percentage of people who might not be eligible because of the the multitude of other medical problems they've got, be it cardiac, neurological, surgical, etc. Because of other medical reasons, they might not be eligible for transplant. So apart from transplant, the other two modalities available are hemodialysis and peritoneal dialysis. As you can see in the cartoon on the left side, hemodialysis is where you depend on a machine. We take the blood out. Hemo means blood. Dialysis means purification. So you take the blood out, clean it through the machine. So there's a filter, and then we clean it through the filter, give it back to the person, and then the person goes home. This is the most common one in India. So most people who are probably attending this talk will be aware of hemodialysis. However, peritoneal dialysis is not something which is very popular for various reasons, unfortunately. It is much more popular in many parts of the world. It could be the European countries, Hong Kong, etc., the Australasia, New Zealand, etc. It is quite common. Even there, the proportion of PD has gone down over the years for various reasons, and the proportion of hemodialysis has gone up, but still significant number of patients are on peritoneal dialysis. The next one, please. So as I said, hemo means blood, dialysis means purification. So we take the blood out, clean it, and then give it back to the person. So through the machine, we can regulate the amount of clearance of the toxins and the excess water as well. Water is also toxin for somebody who's dropped his kidney function, so much so that their kidneys are not able to get rid of that water. Water is probably the most important toxin for them. And we need an access to take the blood out and give it back. The best one is a fistula. AV fistula would stand for arteriovenous fistula. We've got an artery. And we've got two types of blood vessels in the body. One is artery, one is vein. Artery has got blood flowing in very high pressure, and vein has got blood flowing at a slower rate, much slower rate, but at a low pressure. We connect the high pressure and the low pressure system. We create a turbulent gush of blood, which is good enough for us to put a needle and take blood out and give it back on the dialysis treatment. The next best is a AV graft. The least preferred is a catheter. However, many of our patients end up having a catheter because they crash land. They come very late, or they don't plan their start of dialysis properly. So when we don't have time, we have to put a catheter, start therapy, put a fistula, wait for the fistula to mature. It will take 2 to 3 months for it to mature. Then change over to the fistula or the graft. Dialysis is mostly done in hospital. Usually standard dialysis is twice weekly, and each dialysis session is usually for 4 hours. Next slide, please. Then we come to peritoneal dialysis. Here, peritoneum is a membrane which lines the inside of our abdominal cavity. Inside our abdominal cavity, apart from the various organs, there is a dead space which is lined by this peritoneal membrane, and it's called the peritoneal cavity. This space can easily accommodate about 3 liters of fluid in an adult. And on one side of the membrane, if we have the blood that is inside the cavity, on the other side, we've got plenty of blood vessels where blood is flowing. And we'll stay on the previous slide. Yeah, thank you. So when we put fluid into the peritoneal cavity, the blood will be able to access the toxins. The fluid will be able to access the blood, which is filled with toxins. So it will, since the fluid doesn't have any of the toxins, including the creatinine, urea, it will draw all these toxins into its cavity and the excess water as well. See, this water, the peritoneal fluid water, it comes in bags which are done in very clean environment, and it contains very minimal amount of electrolytes like sodium, potassium, calcium, magnesium, bicarbonate or lactate, and then it will have glucose as a osmotic agent. So we need to increase the osmolality of this water so that it can draw solutes from the blood compartment. So we have to place a catheter, which is a minor surgical procedure. The catheter will stay in the body. And I will show you more about how to do the therapy later on. So we fill fluid into the cavity and then drain it periodically. This is a home therapy and this is a self-care therapy. Hence, it is quite popular in many parts of the world. Next slide, please. This picture shows you how the catheter comes out from the body. Most of our Indian patients are not extremely obese, so we do take it out from the lower part of the abdomen. The catheter goes into the abdomen below the belly button, that's umbilicus. We tunnel it under the skin and take it out from the right side or the left side in the lower part. In some countries like Canada and USA, people are quite obese. So if we take the catheter out from the lower part of the abdomen, because of the huge belly, they cannot see the exit site and clean it and dress it. So we usually take it out and bring the catheter out from the upper part of the tummy or even from the sternal area in the chest, in the front part of the chest. So you can see that the catheter comes out and then there's a metal connector. Yeah. So the piece of catheter beyond the metal connector and the plastic part at the very end, that is called the transfer set, or that is what we change every 4 to 6 months or so to avoid infections. And there's a white cap at the very end. Whenever we have to do the treatment, we remove the cap and then connect the bags to the nozzle, which is under the white cap. Next slide, please. This cartoon shows the two types of peritoneal dialysis that one can do. On the left side, you've got something called as CAPD, stands for Continuous Ambulatory Peritoneal Dialysis. As the name says, it is continuous. We have to do it for a long period of time, or maybe 24 hours a day. Ambulatory. So the person is ambulatory. The person is not lying down or something. So you can see that the gentleman there, when the exchange is going on, usually an exchange takes about 30 minutes. An exchange would mean taking out whatever fluid is there in the tummy and then filling in fresh fluid. So removing the old fluid and filling in the fresh fluid would take about half an hour or so. You can see that at the top, it says a drain. So once that gentleman has connected himself to the catheter, he drains whatever is there in the abdomen. So we can see that there's a bag hanging down from the settee, that the sofa. Initially, it is empty. And then on the second one, you can see that that one is full. And then you start filling the fluid in. So that the fluid on the stand, on the IV stand, is the fresh one that is going inside his abdomen in the second picture. And then after that exchange happens, he will disconnect himself from that bag, put the cap, roll the catheter, put it in a small belt, and then off he goes. He can do whatever he wants. He can go for shopping, he can do his home chores, he can do his study, work, or watch the TV, whatever it is. So typically, CAPD, people do 4 exchanges per day, 4 bags per day. Each one might be about 4 hours or so. And then maybe during the day, they will do 3 exchanges and the last bag will stay in the abdomen all through the night. So it is a 24-hour cycle. In India, more bags would mean more cost. So most of my patients are on 3 bags rather than 4 bags. It's only when the push comes to shove, they agree to have the 4th bag because of cost. Everything is about cost. So most people would have 3 bags per day, and they do it every day. So this has to be done every day. It is continuous ambulatory. So people are ambulatory. As they have got the fluid in the tummy. There might be some amount of distension and discomfort initially, but after a period of time, you get used to it, and then you carry on with your work. So in a day, you just do 3 exchanges, and you lose 1.5 hours. The rest is your time. The dialysis is happening inside. You're not even aware of it. On the other hand, APD stands for automated peritoneal dialysis. Automated stands for something which is happening mechanically, automatically. You can see that there's a machine on the table with some bags of fluid. So these bags are 5-liter bags, whereas CAPD bags are 2-liter bags. Usually you get 3-liter bags as well. Usually they're 2-liter bags. For kids, you get smaller 1-liter bags as well. For adults, it's usually 2 liters. But the APD bags are 5-liter bags. So you put it on the machine. There's some amount of programming of the machine to be done. And then you connect yourself, you sleep off. The machine does all the work. In the morning, you just disconnect and walk away. When, in the evening, you again set up the machine, have your lunch, everything. When you're ready to retire, you just come, connect yourself, and the machine will do everything. So that is automated PD. Both of them are choices available for all patients, but cost constraints make them decide to go for one as against the other. Next slide. This picture shows you the Baxter PD cycler machine with a bag on top of it and two bags on the side. And the blue one at the front is called the cassette. So that cassette itself costs about 700, 800 rupees. So the reason why it becomes costly is, one is investment for the machine, which can cost about 5 lakh. However, Baxter does give it on a rental basis as well. And then these bags and cassettes, all these things cost money. We'll talk about money a bit later. Next slide, please. Now, comparing hemodialysis versus peritoneal dialysis. What is the frequency of dialysis in hemodialysis? Usually it is 3 times a week. In the rural areas, in places where governments are subsidizing or totally funding hemodialysis, they might fund only twice a week dialysis. The third one, the person might have to pay and take it. So majority of patients, because of cost constraints, might be doing only twice a week dialysis. However, more the merrier. For somebody, I'll just digress a bit and then tell you what I have not put in the slides here. For somebody who cannot have a transplant, the next best therapy is slow daily hemodialysis. Gentle. So there are centers in multiple parts of the world, Canada, France, UK, where people who are working or otherwise come in the evening, connect themselves to the hemodialysis machine and stay on it for 8 hours. They might not do it every day, 7 days a week, but they do it 4 times a week or 5 times a week. They stay on the machine for 8 hours or so. The blood flows are very, very gentle. So usual dialysis that we do in India, the blood flows are kept at 250. In the West, blood flows are kept at 400. They don't even go below 400. In India, very rarely do we touch 300 ml per minute of blood flow. On these gentle dialysis, they run the blood flow only at about 150, and they stay on the dialysis for a long period of time. These people have pretty much the same quality of life and longevity of life as somebody who's had a cadaveric renal transplant. Okay, so 3 times a week dialysis is actually a compromise. Anything lower than that is actually very substandard. But that is what majority of people across the world can do, or insurance companies or governments can afford to support them. So typically it is 3 times a week. Each session is about 4 hours. You've got an access. Access could be, as we talked before, it could be a fistula, graft, or a catheter. It is usually done in hospital. We can do home hemodialysis, but there will be cost associated with it. And it is not very popular in India. However, home hemodialysis is very popular in many parts of the world, including the USA, Canada, Europe, Australia, etc. The cost, once again here, madam, do you want to go for the... Can you change the view, please? Madam? Can you go to the slideshow view? Left-hand bottom corner. Yes. Yeah, there we go. So in many, so we'll stay in the previous slide itself. So as I said, the cost could be free for people who are subsidized by government schemes, or they're fully supported by their insurance companies, or if they're paying for themselves, depending on where they are, certain units might charge 1,000 rupees per dialysis or 600 rupees per dialysis, and certain centers might charge even 4,000 rupees per dialysis. So the cost might be very, very variable, but it could be somewhere between 0 to 40K. per month for most people. But you have to add the cost of travel and everything, time also, of the person who does dialysis and the person who's a carer who brings the patient to dialysis and takes him or her back. However, PD is a daily therapy. Whether you are on APD or CAPD, it's a daily therapy. So if you're, and the duration can be somewhere between 12 to 24 hours. So typically CAPD is 24 hours, and that is what gives you the maximum amount of dialysis. Access has to be a catheter. We cannot have any other access. And we do it at home, or you can do it anywhere, as long as it's a clean place. It could be a workplace. I do have computer, software engineers who go to work. Their workplace, HR and their colleagues are very supportive. They found place for them to do the exchange in a neat way, and it only takes half an hour. So they do the exchange at their workplace itself. So very much possible. Cost comes up to somewhere around 35K for 3 bags per day, to about 60 or 70K for somebody who's on APD. In automated PD, as I said, the cost of the cassette is quite prohibitive. It is about 800 rupees per day. So that adds to the cost. So it comes up to about 65K per month. Next slide, please. Let's talk a bit about the advantages of each therapy. Hemodialysis. It is intermittent, not daily. Many people, feel that they're on dialysis all day, every day. So they tend to choose, hemodialysis because it is intermittent, whilst PD is daily. It is short duration. So in 4 hours, I can do as much dialysis as what I can do in 48 hours of peritoneal dialysis. So 2 days of peritoneal dialysis is equivalent to 1 session of hemodialysis, as it were. When I say no patient involved, I should say minimal patient involvement. You don't have to do anything apart from give you a hand, and the nurse will put the needle and connect you to the machine, and everything is taken care of. So because of this and the fact that it's done in hospital, people feel more confident going for this process. Cost factor is another major, factor which sways people's decision towards choosing hemodialysis. And because PD is not covered by insurance as of now, some insurance companies do cover, some cover 50% or so, but then nothing is cashless. So they'll have to buy the consumables and then apply for reimbursement, and sometimes they get, sometimes they don't. Few years ago, it was covered quite nicely, but now it is not. Hopefully, with the efforts done by Peritoneal Dialysis Association of India, they hopefully will start covering soon, but we'll have to watch the space. Next slide, please. The advantages of PD is that it's a very slow and gentle therapy. Hence, you don't have that huge yo-yo phenomenon that we see in hemodialysis. So when I say yo-yo phenomenon, what happens is, when somebody comes for hemodialysis, their creatinine might be something like 7, 8, 9, 10 or something like that. 4 hours of dialysis will bring it down all the way down to 2 or 3. Urea will be 60, 70. It will come all the way down to some, 10, 15 or something like that. Within half an hour, all of them will start increasing. By 1 hour, it will be, if the creatinine has come down to 2 from 10, by 1 hour, it will be maybe 4. By 1 day, it is maybe 6. By 2 days, it is back to 10. So everything goes up. So we bring down the creatinine, the fluid level. So most people end up getting 2 liters, 3 liters, 4 liters out. So the body doesn't tolerate all these things. So they finish dialysis, they feel really groggy, very tired, and their blood pressure sometimes goes very high, or sometimes crashes, goes very low. So all these fluctuations are not there in peritoneal dialysis because it's a very slow therapy. Since it is slow, it has to be extended. That's why we do it for 12 hours or 24 hours and pretty much on a daily basis. But the advantage is that people don't feel something is happening inside, and they carry on with their life as normal. Because of this, it preserves the residual renal function. When I say residual kidney function, when somebody starts dialysis, most of them would not be having zero urine output. They would be having some urine output, but it is not quality. Some people might be having 500 ml of urine per day. Some might be having 1 liter. Some might be even higher. That is lost on hemodialysis because of these huge fluctuations in blood pressure and dehydration, forced dehydration, which is induced in those 4 hours. They lose their residual kidney function within 6 months to a year. So from having 1 liter of urine output at the start of hemodialysis, they might be down to 200 ml, 300 ml within 6 months, and it might be zero by the time they hit 1 year. That doesn't happen in peritoneal dialysis. Because of this very reason, it is very friendly to the heart. There are no drastic fluid shifts, and because they are not having a lot of edema, their blood pressure control is also much better. Heart problems occur because of two reasons. In hemodialysis, most people have problems because of heart attacks and heart failure, which happen usually early morning after the long gap. So if somebody is dialyzing Monday, Wednesday, Friday, there's a 2-day gap between Friday and next Monday. So Sunday night, Monday early morning is the most crucial time for them when they're having a lot of fluid and the potassium can be very high, causes problem to their heart. That doesn't happen in peritoneal dialysis because they don't have excess of fluid and salt. The blood pressure is also better controlled. So that is going to reduce the risk of heart attacks and strokes. So it's very friendly to the heart, and blood pressure control is excellent. With regards to the toxins in the blood, we divide them into small solutes, middle molecules, and large molecules. Clearance of the small solutes like creatinine and urea is quite good in hemodialysis, but clearance of middle molecules, which also play a major role in causing the problems associated with kidney failure, they're not cleared much at all in hemodialysis. There is another modality called hemodiafiltration, which is not widely available in India. That seems to clear middle molecules much, much better than hemodialysis, but it is prohibitively costly. Even in centers which offer it in Bangalore, each therapy costs about 4,000 rupees or something. So it is prohibitively costly. So majority of people cannot afford it. On PD, the clearance of middle molecule is much better. So you see that one example that I can give is you might see that people who start hemodialysis, after 6 months, after a year, you see that they're much more tanned than they were a year ago. The skin becomes darker because these middle molecules are not cleared very well. They deposit on the skin and then make the skin more prone for, they makes the skin more photosensitive. So these people tan much quicker. Patients on PD don't tan as much, so their skin quality and color is much more maintained as compared to hemodialysis. That is one visible thing that you can see. Other invisible things are also there. These middle molecules can cause a lot of bone issues, cardiac issues as well. So since clearance of middle molecules is much better, these people have much better outcomes in terms of other things like cardiac issues, and as I said, cosmetic like the skin. On hemodialysis, people lose blood every time they come on dialysis. That doesn't happen on peritoneal dialysis. So anemia is much less common, or the need for erythropoietin is much less as compared to hemodialysis. So there is a cost saving in that as well. So these are all the medical advantages. Now coming to the personal advantages for the person, it's a home therapy. You don't have to go anywhere. You don't lose any time at all. You just have to spend 3, half an hour sessions a day to do your therapy, the exchange. And even when you're doing the exchange, you can be watching the TV, or you can watch, you can read something, etc. There is a lot of flexibility. On a particular day, if you want to go for shopping and you cannot do 3 exchanges, you can only do 2 exchanges, nothing is going to happen. If on a particular day you want to go for a day out and you cannot do all the 3 exchanges, you can just do 1 exchange in the night, no problem. If you're having to miss one whole day because of certain commitments, usually nothing will happen. But that should not become a habit. So that's what I tell my patients. So from once a week, from once a month, missing one exchange, then you come to once a week, then it becomes once in 2 3 days, then it becomes daily. That is not acceptable. But you've got flexibility. If you've got some commitment in the morning and you see that if you miss one exchange, you end up having problems, you can always do it late. Instead of starting at 8 in the morning, you can always start at 10 in the morning. You can finish whatever commitment you've got early in the morning and then start with therapy. So there's a lot of flexibility for a person, which is great. It's self-care. Self-care is always very good. Whatever we do for ourselves is always the best. So you don't have to depend on somebody else to care for you. And that is very good. And most people in the West, they like that aspect of peritoneal dialysis. Quality is assured. These bags are pristine, they're very clean, and they're the same whether you are in Bangalore, whether you're in Bijapur, whether you're in Lucknow, or whether you're in Delhi, which is not the case with hemodialysis. You can see hemodialysis centers mushrooming in every small nursing home, which has got even 10 beds, or even standalone centers, which are run with very poor quality water, poor quality technicians, poor quality machines. That is not the case with with peritoneal dialysis. You are assured of the quality, and the person who's doing it is the best person in the world, which is yourself. So the consumables are quality, and the person who's doing is also very well trained. So the quality is very assured. You can do it anywhere. If you want to travel to Jaipur, you want to travel to Ranthambore, or Bandipur or something, you can take the bags with you for 3 days and do the therapy. As long as it's done in a neat, clean way, the way it has been taught to you, it doesn't really matter. That's not the same with hemodialysis. You'll have to pre-plan properly. You'll have to arrange your dialysis session wherever you're going. If there's no dialysis facility available nearby, you cannot travel to those places. So coming to the next point, traveling is not a problem with peritoneal dialysis. Anywhere, any nook and corner of the world, even say if you want to go to Dubai for a month, you can ask Baxter to supply the bags there to that particular address. It could be a hotel, it could be a friend's place, it could be a relative's place. They will deliver. Cost is a factor, yes, but then possible, yes, it is definitely possible. People on peritoneal dialysis have the least dietary restrictions. Their ability to drink water, ability to take potassium. These are the two most important things for a dialysis patient: potassium and water. Pretty much unrestricted, which is not the case with hemodialysis. Yes, their protein restriction goes away, and in fact, we ask them to take more protein even on hemodialysis, but they have to be on the maximum amount of protein on peritoneal dialysis because there's some amount of protein lost in the PD fluid. But otherwise, their ability to take fluid is very good. They can have potassium-rich fruits and vegetables as well, very easily, because they're on continuous therapy and constantly it is coming out. As they're eating, it's coming out. They have least number of hospital visits. Initially, they come and see me after we start them on PD, maybe once a week, then once after 15 days and once a month. After they're set and they're on auto mode, after 6 months, they come and see me only when they have a problem. Otherwise, monthly visits are done by the PD nurse at home. Blood tests are done on a monthly or a 1.5 month basis. They send it to me. Everything is going fine. They only come and see me when there's a problem. So the least number of hospital visits. I wouldn't recommend them not coming and seeing me. I would still recommend them coming and seeing me once in 1.5 months, but they don't. That's what I'm trying to say. And then there is no carer burnout. What happens with hemodialysis is there is one person who needs to be looking after the patient all the time, bringing them to the hospital, taking them away, supporting them in the hospital, doing the billing, taking them upstairs, negotiating with the nurses, fighting for the patient, remove this much fluid, remove that much fluid, potassium is high, person is having breathlessness, please start early, blah, blah, blah. All this, nothing of that happens. So the carer burns out on hemodialysis after a period of time. It might be 6 months, 1 year, 2 years. They burn out. That doesn't happen with peritoneal dialysis. Hemodialysis, disadvantages of hemodialysis. We talked about the advantages of hemodialysis, now the disadvantages. So we once again got the medical and the non-medical. Medical, poor blood pressure control. While PD patients have got better blood pressure control, HD patients have got poor blood pressure control because 99% of blood pressure regulation is because of the excess or not excess salt and water in the body. Hemodialysis patient, once they finish their dialysis, they intravascularly quite dry. They might still be having swelling in their feet. They might still be having fluid in their lungs, but in the blood vessel, the blood compartment is very, very dry. After 2 days of dialysis, they're overfilled, their blood pressure is very high. So that, effective blood pressure control is not good at all. The fluctuations in the blood pressure, fluctuations in the potassium, urea, the body, including the brain, the heart, don't tolerate it very well. They might not shout out and cause problems, but they are suffering silently inside, which is obvious after a long period of time. As we talked, loss of residual kidney function is very early on hemodialysis as compared to peritoneal dialysis. Then you've got fistula-related issues. So there's something called as a steal phenomenon, because we have shunted large part of blood coming to the hand, away from the hand will suffer. So most people will feel that on the fistula side, the fingers are a bit cold. Sometimes they might be white or even blue, because of which they might develop some weakness in the hands. Most people don't, but some people, especially diabetics, do have these problems, which is not there in peritoneal dialysis. Now, the non-medical things, hospital visit, you have to come to hospital regularly, 3 times a week. And there's rigidity of therapy. If you're given a slot at 9 o'clock, you have to be there half an hour in advance. And then you might still not start at 9 o'clock because there's somebody else who's sick and unwell and he has to start before you, or somebody who's on the dialysis needed a bit extended therapy and has not come out of dialysis, and you have to wait for him or her to finish. And the whole session, although it is a 4-hour session, starting at 9 o'clock, you have to leave home at 7 o'clock. You finish dialysis at 12 or 1 o'clock. By the time you reach home, it is 2 o'clock, 3 o'clock. You reach home, you feel tired, you sleep off. Evening, you wake up, you've lost the whole day. So there's a lot of loss of time for the patient and for the care. Most people will have a fistula, so there's a needle prick, which most people don't like. Then we talked about the fluid and diet restrictions. Although you're on dialysis, you're still having restrictions. Then we've also talked about travel restrictions, which are there in HD as compared to PD. The last slide, disadvantages of PD. You can see that while the advantages of HD are smaller and disadvantages are big, the advantages of PD are many and disadvantages are very few. And these few all relate to the catheter. One thing we cannot avoid is a catheter. Any catheter in the body is a risk of infection. So that is the main problem. However, if you look after it properly, the way you've been taught, people can stay on PD for a long period of time. Yes, there are restrictions in terms of inability to swim and things like that. That is to make sure that the catheter doesn't get infected. If somebody looks after the catheter well and avoids infection, they can stay on PD for many, many years. We have people who've been on PD for 5 years, 7 years, 8 years. They are very few, because most of our patients, after 6 months, they become a bit overconfident. They start cutting corners. They'll have PD infection. Once you have an infection, you change the quality of the peritoneal membrane, and then the membrane starts failing, and you might not be able to stay on PD for longer. Most people in India stay on PD for about 1.5 to 2 years max. After 2 years, they start failing because they've had a couple of infections, which changes the quality of the PD membrane. We can still manage. There are people with zero urine output, with high transporter status. We can still keep them on PD. But the prescription given by the nephrologist might become very prohibitive for that person, and he or she might feel that changing over to hemodialysis might be the best option rather than doing such rigorous prescription of the PD. So the shelf life, as I said, might be about 2 years in India, but do it properly, look after your catheter properly, do what the doctor says, you can stay on PD for much, much longer. Cost, as I have seen, This is the single most factor which shies away most people who are quite willing otherwise to do PD to choose hemodialysis. They've been paying the insurance premium for donkey's years, and now when it is time to encash on it, if the insurance company doesn't pay, they don't want to go for peritoneal dialysis. So last but not the least, I think we have talked about the cost already. So cost on HD can be anywhere from 0 to 45. On PD, it is about 35,000 to about 65,000 per month. In PD, you don't have additional cost of travel. The additional cost of travel is there. In HD. The cost lost for the carer in terms of time is, you cannot put a financial value to it. It's invaluable, which is not the case in peritoneal dialysis. And in my mind, for anybody who hits CKD stage 5, PD is as good a choice as compared to HD, medically. But from non-medical reasons, the PD scores over hemodialysis for a couple of medical reasons, like blood pressure control, the cardiac protectivity, renal protectivity. PD definitely scores over hemodialysis, but that edge is lost after the first couple of years or so, because they lose their kidney function, etc. That residual renal function, benefit, wanes away after a couple of years. So the cardiac protective effect also goes away after those couple of years. With those few words, I'm going to end my session. Thank you.
Thank you, Doctor, for taking us to that journey of explaining to us the difference between the peritoneal dialysis and the hemodialysis. That was indeed a wonderful presentation, and this brings us to the end of part 1.